Sanjay Dutt was diagnosed with stage 4 lung cancer.
Actor Sanjay Dutt has been diagnosed with cancer.
संजय दत्त लंग कैंसर की थर्ड स्टेज से गुजर रहे हैं.
Mr. Sanjay Dutt was told he has very little time. And he said, I'm going to defeat it. This was my first conversation. I'm going to defeat it.
I mean, what is cancer? I mean, I've fought so many battles. I'll fight this thing.
He had an exceptional and magical response to immunotherapy. We took him off all therapy last 3 years. He's been on nothing. And there's no disease. Cancer treatments are evolving. If you can keep yourself alive for the next 5 years, things could be completely different. The drug that I could not give to my mum, that drug has already launched now and can be given to the next patient.
In India.
It's a my mum, I lost her 2 years back of advanced lung cancer. She presented some features that felt like acidity, and we found metastatic disease. This was already spread into various organs, and it's that day and today when I really can't put down a symptom. Every person should be aware of what are the age-appropriate cancer screening methods that are globally approved. It's different in males and different in females. The routine blood tests are not the best way to detect cancer. There is emerging cancer detection, it's called.
People think cancer is inherited. How much risk comes from genes and how much from your environment?
For now, we know 10 to 20% of cancers are inherited. What happens to the 80% of others who have non-inherited cancers? It could be...
Sanjay Dutt was diagnosed with stage 4 lung cancer.
That's correct.
Which is usually means it's incurable and you're at the end of the thing.
Yes.
No? What is the average prognosis, or let's call it life expectancy, for someone who has stage 4 lung cancer?
When we think of anything stage 4, we think of a terminal illness. But I would say lung cancer actually has transformed the expectation of survival in lung cancer, or any cancer for that matter. There are two types of lung cancers largely. I talk about smokers' lung cancer, non-smokers' lung cancer. And when we have non-smokers' lung cancer, we treat with targeted therapy. When we have smokers' lung cancer, we treat with immunotherapy. Chemotherapy may be involved as well. And in his case, he had an exceptional and magical response to immunotherapy. And, the rest is history. His disease went into complete resolution almost right away. And we took him off all therapy last 3 years. He's been on nothing. And there's no disease. So he's really, really done well. And if I give that as an example, there are scores of patients globally who, even with advanced lung cancer, are living normal lives. They have, they're enjoying good quality of life. Their diseases are in control. And so we say in the precision world that lung cancer is actually the poster child for precision oncology, because you have to diagnose, figure out the type of lung cancer, and then strategize management to the particulars of the diagnosis.
So, like you said, the patient is the hero. That's what you were saying. So in Sanjay Dutt's case, how was he the hero?
So I feel very strongly that it's not the doctor, it's the patient who's the hero. Because how you deal with that message of a diagnosis, how you deal with the message of an advanced cancer diagnosis. If you've heard him speak, many, many times he has just said, I did not believe it.
Oh.
I just did not, I decided to not internalize it, essentially. So, and he said, I'm going to defeat it. This was my first conversation. I'm going to defeat it. I'm going to be your first patient that you're going to be proud of. And so, dialogues like that. And these were all, these dialogues were not out of a movie. These were out of his real life. So they are the hero, actually, because they are able to generate that energy from within to decide to fight back.
Is cancer mainly a disease for smokers and older people?
So when you see the median age of presentation, you see a 60 and a 65. But in India, we are seeing at least 10 years younger patients present. We commonly see non-smokers and young adults present with lung cancer. So it is something that is to be studied. but definitely a myth.
Got it. If nobody in my family has cancer, am I completely safe?
Completely is the wrong word. Never completely safe. Always keep that statistics in mind. 1 in 2 men, 1 in 3 women. So 80% of cancers are non-inherited. It can happen to anyone. So everyone is at risk.
So I want to ask you about an executive check, because now
Yes.
a lot of people are doing an executive check that they
Right.
managed to, which is just blood test. Chalo, I don't have to visit the hospital, I'll do blood test. People are okay with that. Morning, some guy comes. That's the minimum which people can do. How good or bad is the current executive blood test to detect or screen for cancer?
So the current executive check actually includes tumor markers. Tumor markers for gastric cancer, for breast cancer, for ovarian cancer, for pancreas cancer, liver cancer,
Prostate also, I think.
prostate cancer. But mostly, other than prostate, mostly the other tumor markers, when they are already found to be elevated in blood, it's already late. Already the cancer has spread. Other than PSA, which is for prostate, and AFP, which is alpha fetoprotein for liver cancer, where it may still be in early stages. If someone has CA19-9 elevated, the pancreas cancer is most likely already gone places. Similarly, CA15-3. And I'm not talking about minor elevation, because, mind you, minor elevation of tumor markers can happen due to multiple physiological reasons as well. It's not essentially all related to cancer.
So blood is not the best way to detect cancer.
Blood is not the best way to... The routine blood tests are not the best way to detect cancer. There is emerging liquid biopsy methodology for cancer detection. It's called MCED, multi-cancer early detection tests. These are currently at large being experimented globally. They are also commercially available, but you have to take them with a little bit of understanding. And there has to be pre-test counseling, post-test counseling as to what they mean. They're not 100%, but they definitely flag off who is at risk, who's at low risk, who's at intermediate risk, who's at high risk. So at least that blood test is much more specific than what we have today.
For every family watching this, what screening should everyone do? Because there's so many different things. And nobody's telling you to do, like you said, a preventative cancer screening. The doctor will say, "Arey, chhod do. Forget about it." So what is can you give us guidelines for what screenings family should do?
We, in India, we just don't practice a well visit. In corporate setups,
What is a well visit?
well visit is when you are well, but at once a year, you go to the doctor and you get checked out. So that well visit actually starts as soon as you get your insurance in the West. So you become of age, you get your own insurance, and your well visit once a year starts. Okay. When we look at cancer screening for men, in those well visits, there are tumor markers that you get done. There is colonoscopy that has to be done in once in a decade. There's prostate screening that happens. And then, of course, any symptom-related screening would also be discussed by the practitioner, the general practitioner. When you look at a woman, it definitely starts at 50, but in some situations, it starts 10 years ahead of your first relative that had breast cancer. Let's say a first-degree relative had breast cancer at the age of 45. The daughter will start the screening at 35, actually, 10 years ahead. So when I say that, I'm just going to outline in men, let's say there is a smoking history. There is enough and more data for the last 2 decades to do low-dose CT scans. How many centers run low-dose CT scans? In Bombay,
None.
in Mumbai, if you just look at it, how many centers are running screening low-dose CT scans? None.
So you can't get one.
No, you can. Low-dose CT scan options are available at every center, but they're not running those programs. Nothing.
They're not telling you about. No one is educated.
People are not disclosing their addiction. They are consumers. They are dependent on tobacco, they're not declaring that. They're not writing it into their insurance. They're not mentioning it in their health checkup. They're not getting the low-dose CT scan done. That's one thing. For women, so many women come to us in our clinic when they've not had the yearly mammogram done. Last time they had it 3 years ago, 5 years ago. There's no reminder. There's no
reminder,
routine.
yeah.
There's no practice. No one is reminding. Nor their insurance, not their corporate that they're working for, not their families, not their friends. There is no culture. I talk about it all the time, the psychology of screening. Psychology of screening brings in fear and aversion.
Culturally, it's not there in our
It's just
brain.
not there.
Got it. That's so interesting. And why, you said it, that people are not thinking of cancer. And therefore, the next thing is when they get it or when someone gets it, they're just not prepared. Why is that people are not thinking of cancer and therefore never prepared for it?
Cancer has forever been associated with death and dying. So whenever there is something that is that stark, our routine psychology is you don't want to visit that topic. You want to change the channel. You want to look at something more
Fun.
Fun, happier, less stressful. But for the reality that this is now in all our homes. If you look at the Globocan data 2023 and the projection, 1 in 2 men and 1 in 3 women will be affected by cancer in their lifetime.
Oh. So the executive health checkup is not good enough?
It's not good enough.
So what should someone add to the executive check, a 30, 40, 50-year-old person, male or female? What should they add?
So every person should be aware of what are the age-appropriate cancer screening methods that are globally approved. It's different in males and different in females. And we just need to be fully aware of what is there. So if we are talking about a male, smoker, non-smoker, accordingly, tobacco chewer, non-chewer, and things like that. So PSA, colonoscopy, blood tests, routine tumor markers, I say absolutely go ahead and do them. And then oral examination, lung examination, scan, wherever indicated, all of that. But then there may be a symptom that that person is having for some time. Utilize that time when the health checkup is happening for that symptom. Get an endoscopy. If you're having reflux for a long time, get an endoscopy. Yes, it is time commitment. Yes, it is involved. But I would rather have it that way than to ignore a symptom and result into something, say a year down. That's not game.
Got it.
Second thing that I would like to mention here is there are certain umbrella tests where liquid biopsy is emerging and also whole body imaging. So I say do the easiest first. Look at the risk that is being flagged off from all the tests that you're doing. And then if there are risks being flagged off, don't shy away from a whole body imaging. Now, I have to say this is a disclaimer that neither liquid biopsy nor whole body imaging are standard of care, but only paranoid survive.
How good are liquid biopsies for detecting cancer?
I would say around 20 different kinds of liquid biopsies are already launched globally for early cancer detection. They're called MCED, multi-cancer early detection. We have to be very careful when we utilize them because what we are looking at is their sensitivity for early stage cancers. Because they have to be able to pick early stage cancers and flag off early stage cancers really to make an impact on survival. That's where, as a consumer, we need to understand which one is best for us. A lot of these tests have still not come in India, but those of us who have access to global testing need to be aware when we do the test. What is the sensitivity for stage 1, stage 2? Because if a cancer is diagnosed in stage 3, stage 4, that is already quite advanced. We want to catch them very, very early. So choose a test, choose a liquid biopsy that would have high sensitivity and specificity for early stage of different cancers. Liquid biopsy, first of all, is a blood test, right, in specific tubes. Then the blood is taken to the lab where different kinds of materials from the blood are representing cancer. So some lab is studying one particular fact, the other lab may be studying the other fact. Different methodologies to come to a similar prediction whether this person is at low risk for cancer, intermediate risk for cancer, or high risk for cancer. If someone gets flagged off as intermediate and high, investigation should be done starting with the standard of care investigation, whatever they are supposed to get
For
as
that
standard of care screening. And then if nothing is found, then I say get a whole body imaging.
How accurate are liquid biopsies in detecting various stages of cancer?
Various liquid biopsies will have different accuracies. So we as a consumer have to ask that question.
I see.
You have, before you do the tests, and these are not very cheap tests. They are expensive tests.
What does a liquid biopsy test cost? In India?
In India, it would cost somewhere around 1 lakh.
For one test?
For one test.
For one cancer?
It's a pan-cancer testing.
So one test is enough?
One test is enough for that year.
For that year?
Yes.
So 1 lakh rupees for
1 lakh rupees, or, in that ballpark. But if you're doing an international test, it's threefold the cost.
Got it.
Double the cost or threefold the cost.
Got it.
So if you're engaging into a liquid biopsy test, we better be sure that that liquid biopsy test has a high sensitivity for early stage.
When a family sees a report and it says suspicious for malignancy, everybody panics. What does that mean? How does a family read that report?
Whenever something is gray, I say it's a good news. It's a great news. We can't be fearful of that. See, we have to become very thick-skinned to face this. Otherwise, we will always be fearful and wait our turn.
Solution.
Because the numbers are out there. The numbers are out there. It is going to happen to X number of people.
1 and 2, you and your best friend, one of you are going to get it.
So, if it is going to be that way, I would rather always be cross-checking and not be averse to looking at the report. So, if it is saying suspicious, it's still not saying it is. Whenever there is a gray area, I always say there is a very high chance of the test coming back as negative. Don't be shy, engage, figure out whether it is or not.
A cancer diagnosis subtly introduces a bunch of words like type, grade, stage, receptors, biomarkers. How do you make sense of all these words?
Stage 1 and stage 2 are early stage. Stage 3 is locally advanced. Stage 4 is advanced cancer. Earlier, people would call it terminal. Now, a lot of people, even with stage 4 cancer, are living with good quality of life because there are many, many excellent medications.
Doctor, I want to ask you, what is cancer and what makes it so unique?
So, cancer is an autonomous multiplication of body cells. A particular part of the body, the cells there, start to multiply autonomously without control. That then becomes aggressive. It metamorphoses, changes characteristics. It changes its original look from where it is originating. And then it starts to slowly travel out of its primary organ. First, they become different.
I see.
They become angry. And then they start to escape the confines of that organ, escape the confines of the capsule of the organ maybe, and traveling through blood system, lymph system to other parts of the body. So initially the travel is local, and then the travel can also be distant. And that's what is called metastasis. If you look at a cell at an integral level, there is a mutation. We use the word mutation. And you've seen sci-fi movies where there is a character that mutates.
Yes.
So cancer cells also undergo mutation and they become different. They become angrier. As they mutate, And these mutations could gather up, make the cell angrier, and a collation of cells then happen. And those become bigger and bigger and uncontrolled proliferation, and then the metastasis.
Most people think cancer is inherited. How much risk comes from genes and how much from your environment?
For now, we know 10 to 20% of cancers are inherited. And I'm stretching. It actually, if you really look at hard facts, you may probably be able to come down to like 10% of cancers are inherited. So what happens to the 80% of others who have non-inherited cancers? And a senior once said, it's sheer bad luck. But actually, if you tease out the bad luck, it could be lifestyle, it could be obesity, it could be the two major risk factors, alcohol and tobacco, it could be sun exposure, it could be environment. So the main ones that we recognize are the lifestyle that we talk about, tobacco, alcohol, environment, infection, light, UV exposure. So when we say environment, you're actually lumping in a million things together. It's the food, the water, the air that we breathe, chemicals that we apply, soaps that we use, and everything.
So talking about prevention, I just read something that the WHO did this massive report in Feb this year, which said roughly 4 in 10 cancers could be prevented. How is that possible?
How big a reality is that, isn't it?
It's crazy.
It's crazy. And we are, from India, we are actually not even lining up to understand the first one.
Right.
So if you see how many of these cancers are linked. So there is tobacco, there is alcohol, there is lifestyle, there is obesity, there's diabetes, there is sunlight prevention,
pollution.
There's pollution, environment. If one tackles just the cancers related to obesity and diabetes, we would be tackling 13 or 14, maybe 15 of the cancers right away. So that's one cohort. And then when we talk about infection, in India, the most important infection is the human papilloma virus infection. And that 98% of cervix cancers getting caused by human papilloma virus. 98% preventable.
And how many people, like in our audience, do you think are taking that vaccine for HPV?
So the going rate, if you really look, it's so dismal. It's not even 20% as a routine count. If you have to go out in the community and take the percentage.
In our community, basically.
In our community, we are somewhere between 15 to 20% of
women,
vaccination
HPV.
rates. Yeah.
So only 1 in 5, 1 in 6, 1 in 7 women are having HPV. When should you get an HPV? When should a woman get an HPV vaccine?
So it's actually in teens. We are the ideal age to vaccinate begins at 9. So between 9, 11, 13, 14, above 16, you have to take 3 doses actually. So if it's a young, so it's the parent who has to know.
And what if you're 25 or something?
So you can. Up to 40 now, we see benefit from getting the vaccine, but we give 3 doses.
And so you talked about, many areas, I just want to get it all of them, smoking.
Yes.
For our audience, what do you say are the 5 biggest cancer risks that they can change themselves?
So if someone's smoking, that's the first thing to quit. Alcohol, no level of alcohol is game, and that has to go. What we really don't talk enough is obesity and lifestyle. So obesity, lifestyle, diabetes, all 3 together really can be worked upon, prevented. If someone is with diabetes and is obese, sedentary lifestyle, they are at higher risk. They should screen more, be on high alert, of course. Sunlight is not such a big a challenge in India because we have natural protection, because we have colored skin. Then pollution. So those that are more out and about, we are working in exposed areas, certainly need to prevent themselves. And those that live in cities where there is very high AQI, you have to be careful, really be cognizant of what you are exposing yourself to, and try to use preventative methods, wear a mask. Now I'm always scared when I'm telling people, go out for a run.
I know.
You have to be very careful when you say that because of the pollution.
So I'm going to unpack all those things, Doc. Smoking, how much cancer risk comes from smoking, smokeless tobacco, like vapes and all, and passive smoking?
Yeah. Any type of smoking, any type, all the three kinds that you just outlined, and I'll go on to say even marijuana. All of that brings in a very high risk for lung cancer causation. So anyone who's exposed to smoking themselves, are current smokers, previous smokers, past smokers, very, very high risk. Smokeless tobacco cuts the risk, I say 10-15%, but still very high risk. And when we look at secondhand smoking, that too, just you drop 10-15%. But what I say all the time is, it's not the percentage, it's the exposure. Why? Because someone's genes may mutate at a very low level of tobacco exposure versus someone else who may be a chimney smoker all their lives and still may not undergo that mutation. It all depends on what did you inherit, what did you bring to the table, and what did you then expose yourself to. And there is no way to find out. So prevention is key. Stopping smoking is the most important thing.
Or being around smoke.
Shunning that is also most critical. But if someone is exposed, know your risk. Go and get screened. Be diligent in reaching out and getting the screening than being ignorant and guilty.
What do you say to a 25-year-old who's smoking a few cigarettes a day and they're like, I'm smoking 2-3 cigarettes a day?
Any cigarette is barred because of what I just told you. We call it, there's a description for this. This is called collegiate smokers. And it has been shown that even for such smokers who are very intermittently 1-2 cigarettes, 3 cigarettes, maybe in an entire week, there is a particular type of mutation that is seen in these type of smokers who are hardly smoking.
They're saying I'm nothing, kuch nahi.
But they, the thing is that it is what goes inside and helps the mutation happen. So it is a carcinogen. How sensitive you are to the carcinogen? Nobody knows.
Can smoking weed give you cancer?
Yes, it can. And that is why we have to be very, very careful what we think is game.
Most people think it's natural because it's not tobacco. So they, it's good for them because it's natural.
So if you look at the data from in comparison, it elevates the risk at least 2.5 times.
Right.
So any weed smoker would have a way higher risk than a normal person. I will also go on to say something more for non-smokers because we are talking lung cancer.
Because you're hanging out, it's a social thing.
Yes.
I'm smoking and you're sitting near me, so you have to think of you as well.
Yes, exactly.
I'm smoking, it's my problem.
So we have to be aware of what we are doing
the
to
social
the
element
community,
of it. Yes.
the social element, to your spouse, to your children. What are you exposing them to?
Your friends, colleagues.
So I think today it is imperative to at least shun what can be shunned, because the cancer rates are really on the rise. And if this can be 100% preventable, why aren't we doing that?
You talked about alcohol.
Yes.
How bad is it to have a few drinks a week?
So alcohol, just like smoking, has now been connected to very different cancers all across the body. And earlier, I would say 20 years ago, the warning mainly was for tobacco. It wasn't as much for alcohol. And even in certain at-risk population, like especially in women who had breast cancer, it was okay to take up to 4 drinks in a week. The most recent guidelines actually shun every bit of alcohol. So no alcohol is advisable. Why? Because if you see even lowest quantity of alcohol could be involved as a carcinogen, not just when it gets absorbed in the body and impact that it can have on different organs, but also something called field cancerization. So the path that the alcohol travels from the mouth to the food pipe, to the stomach, and then the absorption, the entire path that gets exposed to alcohol is at risk for cancer. And no level of alcohol is considered safe. Starting from cancers of the head and neck, cancers of the food pipe, stomach cancer. I mean, look at how many people come for us. We look at how many people come with stomach cancer. And you try to get their history. Do they have a family history? No. Are they eating anything different? Then you take the history for smoking and alcohol. And there could be a consistent utilization of alcohol. Just as of yesterday, I saw a liver cancer patient who had significant history of alcohol. And these are not people who are thought to be alcoholics. They are highly functioning people.
Social drinkers.
Social drinkers who are drinking 2 drinks a night. You know, and they are highly functioning. They are not the ones who are
what you think?
drunk.
Liver
and,
cancer means the guy is a Deora on the road or whatever.
This is not a Deora at all. This is
Right.
not someone who is on the road. And
Right.
this is a person who's delivering. Point that I'm trying to make is not that people who don't do these will not get the cancer. But people who do these are bringing these insults onto them and contributing to the cancer-causing risk. Right now, we have gone all out to call out alcohol because there have been associations even with least amount of drinking among people.
Clear associations.
Clear associations. And so it's been called out as no alcohol level is safe. To follow or not to follow is a personal choice, but at least we need to know our risk.
Got it. Moving to weight.
Yes.
Weight, GLP, diabetes, metabolic all come together.
Yeah. So when we look at weight reduction, diet and exercise and weight reduction, you're able to change the risk of cancer causation by 30 to 40%. When we look at the risk and secondary prevention, someone's had cancer and then they went into a lifestyle and they dropped their weight, they went into exercising, they really watched their diet. That was found to have decreased the relapse risk, the cancer risk by 30 to 40%. And some of the chemotherapies are unable to drop that kind of relapse risk. So I find this very, very profound. And this is the conversation with every patient that comes in the room, that you have to look at diet and exercise and weight loss. Even a 10% weight loss would really strike that deal.
So which cancers are most associated to obesity?
There are several different cancers that have direct association. And I'll name out a few here, like breast cancer, colon cancer, direct association. Some of the gynecological cancers are directly associated with weight, obesity, pancreas cancer, known to be associated with diabetes, liver cancer, associated with the fatty liver, bile duct cancer. So these are all diseases or cancers of metabolic syndromes where obesity and diabetes come together, sedentary lifestyle, all of that. Even from head and neck perspective, there is enough data today to say diabetics get a lot more oral cavity cancer than non-diabetics.
And GLP-1 drugs like Mounjaro and Ozempic, how helpful are they in cancer prevention?
So that's also a great question. I think the evidence today is mainly that GLP-1 agonists like these two drugs in particular, are able to decrease the secondary cancer risks. What do I mean by that? I mean, if someone has already manifested cancer and they have had a higher body weight, they have diabetes, they have metabolic syndrome, and they took the GLP-1 agonist and dropped their weight, these secondary prevention was significantly affected when they were taking GLP-1. Can this message be taken and utilized for cancer prevention? Not yet. I think it is very, very provocative, but would I do that mainly for cancer prevention reasons? Not really. Having said that, those who are obese and taking GLP-1 for their obesity are seeing improvement in rates of their insulin intolerance, improvements or decrease in rates of cancers that would occur at a much higher rate in them when they were not on GLP-1 agonists.
So, along with weight loss is exercise.
Yes.
What would you say are the best exercises that someone can do for cancer prevention?
When I look at exercise, exercise has level 1 evidence today in the most prestigious cancer journals or medicine journals, where it has been shown that if someone exercises, they have less cancers, they have less cancer relapse, and they have higher survival.
You said level 1. What is level 1?
Level 1, highest level of evidence.
So exercise has level 1 level of evidence, the highest level of evidence to reduce cancer risk.
Reduce cancer risk and enhance survival. It is 3 to 5 times a week of moderate intensity exercise. So if you really look at what is moderate intensity exercise, it is an exercise that lasts at least 45 minutes to 1 hour in a day, where the heart rate has to go up above a certain rate, and the person has to really be doing activity at a higher pace than a very, dormant exercise. But a lot of our patients are not able to be that active because they are under treatment, they are at a certain age. So my mantra is actually to look at the biggest culprit, which is for everything, not just for cancer, which is the sugar surge. So when we eat, everything gets metabolized into sugar, and that sugar level goes up after eating. If you see half an hour later, the level starts to go up, 2 hours later, it is, saturated, then it starts coming down. For that level to come down and for our body to get the least information on inflammation, we need to cut the sugar surge. And for that, I say walk after each meal. 20 to 30 minutes of walk after each meal amounts to nearly 10,000 steps a day. And that is it meets the criteria for moderate intensity exercise in a week.
Because it's after the meal also, it has a double effect.
It has double effect.
Compared to just doing a workout.
That's correct.
So you're saying, that's so interesting. You're saying even walking for 20 minutes after a meal is kind of equal to doing maybe like a swim or a run at some other time because of the connection with the meal.
Yes. So when we say swim or a run, and that's intense exercise for say half an hour or 40 minutes, if you were to spread that and make it 20 minutes or 30 minutes of walk time after each meal, it would amount to similar impact on the insulin resistance that happens across the time period for a subject or a patient, and the impact is profound.
Because you said insulin resistance, so is the main reason of exercise being linked to reducing cancer, the insulin moderation is the main reason?
That's the main.
It's through insulin.
It's through the
insulin is so important for cancer also, because I keep hearing it for metabolism and diabetes.
Insulin is most important for cancer because the whole concept of sugar feeds cancer, which I completely negate, is born out of the concept of inflammation from sugar. And that happens majorly when we take something, whether it's sugar or beyond sugar. When we eat, everything gets metabolized. And
yeah, people will say only sugar, but then they'll have poha every day, which is the same as sugar. So
Not
it's
just that, it's, I say this all the time. Everything that we eat,
everything, right?
you look at a molecular level.
Right.
At a molecular level, it's the fuel is sugar, right?
That's what I mean. Sugar is the only key ultimately.
That's correct.
Whatever
it
I
is the
take.
essence of life. The point is that how we handle that sugar, how do we
Very
spread
interesting.
that sugar? We have to take the essence of life, but we have to spread it out so that it never surges and it never leads to inflammation. And that inflammation prevention has been shown to be critical.
What is the worst food for cancer?
Red meat and anything associated with that really flagged off as something that contributes to inflammation and contributes to inflammatory lack of control on cancer cells and proliferation that leads to spread. So today, if there is one food that we absolutely tell patients to shun, is red meat.
And can you tell us what are the different red meats?
Different red meats, we talk about the highest on this conversation would be beef.
Mutton?
Which India is not utilizing
Yes.
as much. Mutton, of course, yes, mutton is also classified as red meat and is also harmful. But beef is
Sausages,
really,
bacon, pork.
all of that. Yeah. And when we talk about processed meat, that also is considered to be contributing to carcinogenesis. So even when we talk about, sausages, chicken sausages.
Cured, when they're cured.
Cured, exactly. Even from other types of white meat, it's not as healthy. So
All cured meat is carcinogenic, right?
carcinogenic.
Yeah.
So the least we can take, the better it is. But amongst them, if you look, red meat is really on a hit list.
You spoke about the environment. India has a massive air pollution problem. How strong is the link between air pollution, AQI and cancer?
So it is getting stronger by the day. There is, earlier people were speculating, but now there was a very large study.
China?
No, UK.
Oh, UK.
UK, Charles Taunton and team studied 40,000 subjects.
Oh.
And they showed that people who were exposed to particulate matter above 2.5 microns in size, PM 2.5, it just became a very, very famous phrase in oncology and also in prevention groups. People who are exposed to more than PM 2.5 micron of particles, there was a direct cause and effect relationship seen with a non-smoker's lung cancer. So EGFR positive, endothelial growth factor receptor positive lung cancer makes 25% of all lung cancers in India or Asia. 50% of lung cancers in Asia, in some places as high as 80% of lung cancers are caused in non-smokers.
There are so many specific cancers, like you said, prostate cancer, breast cancer, two of the most common ones for men and women. And any other common cancers that you have. Are there any specific things you can do to reduce your chances of getting these
breast
common
cancer?
cancers? Yes.
So for breast cancer, the answer has been explored for time immemorial. And it has been shown that pregnancy and multiple pregnancies actually reduces the risk of hormone-related breast cancer. And if you really look at the numbers, the larger proportion of breast cancers are hormone positive. And so if a woman has had early age pregnancy and has had multiple pregnancies, during the pregnancy, the hormones are protective to the breast. With the current changes in the society and how things have, urbanization, I would say, we have had instances where women are working and active and have delayed their pregnancies, lesser number of pregnancies in those urban areas. We are seeing higher rates of breast cancer. For prostate, it is actually much more lifestyle. So diet, exercise, obesity, more correlating to metabolic syndrome, risk gives higher risk to prostate cancer. And there is some association in prostate with dairy as well. And that concept is coming from the concept of dairy contributing to hormonal imbalance, and hormonal imbalance then contributing to prostate cancer causation.
Wow. Does sugar feed cancer?
So, direct relationship with sugar and cancer, non-established. But we have to cut the sugar surge, which can happen from any food. So, shunning just sugar is not going to suffice. We have to cut down on the sugar surge by diet and exercise.
Can stress cause cancer?
A lot has been done around this. If stress alone were to cause cancer, everybody on Wall Street and stock exchange would have cancer.
Yes.
So no, that's a myth.
Every doctor would have cancer.
Every doctor would have cancer.
Everyone would have cancer.
Every
Poor policeman on the road.
policeman on the road would have cancer.
Although they're getting them, but yeah.
Yeah.
Can Ayurveda, homeopathy and herbal remedies cure cancer?
So I never say never.
Right.
But I say, none of these are safe to be taken with our medications without the knowledge of what they're doing. Ayurveda is made out of so many thousands of different medications. To lump them as just Ayurveda, not good enough. So I don't give them together. If someone has to practice any one of these, they have to do it separately.
Right. So you can't combine them.
Never.
Right.
Never.
Symptoms. We talked about prevention now, but just to understand what could be a symptom for cancer, and you have some obviously very interesting thoughts and anecdotes on that.
Yeah.
One of the most dangerous things about cancer is that there are no symptoms, or the symptom is like anything. You can have a cough, you can have asthma, you can have anything, acidity. It can be any number of mild things which you think is nothing at all, but after some years or whatever, you realize that was the start of my cancer. How does one deal with that? Like, how do we and our audience cope with that thing that any symptom, this cough I have today, could be the start of lung cancer?
So, a friend of mine says only paranoid survive. So, when I look at the rising cancer rates, when I look at what we are going through globally and how much of insult our body is accepting and what it could be doing to us every single day, I think we just need to be on high alert. I would rather be on high alert and check on it more often, more quickly, than be relaxed.
I mean, it's true that you're always like, pata nahi chala. My dad had gallbladder cancer, and he wasn't a smoker, he wasn't a drinker, he was slim, he wasn't diabetic. I didn't believe it. I remember clearly when it happened. I was like, when they took out his gallbladder and they put it for a biopsy and they were going to check, and I remember I said, it can't be anything.
Yeah.
And again, it was found incidentally,
Yes.
but it was cancer. And of course, it was lethal for him. So, Doc, talking about symptoms, can you tell us more about what symptoms we can look for?
So it could be very subtle, Mukul. And we have to be paranoid. I have to say this.
Done.
That you spoke about your dad, and I bring up my mum here. And I've said this to you earlier. My mum, I lost her 2 years back of advanced lung cancer. And she was a practicing gynecologist in her prime, truly in her prime. And very, very active, highly active. And then she presented some features that felt like acidity. So we said, okay, it's GERD. And she said, I would think I need an endoscopy, and I'm just going to come to you and we'll do it there. And she flew in all alone, and we took her to get the examination. Prior to endoscopy, just scanned her. And we found metastatic disease. This was already spread into various organs. And it's that day and today when I really can't put down a symptom. And later on, when I was to return home, Ma was no longer there. And when I returned home, I saw inhalers kept in various drawers and certain medications that told me she was having breathing issues. So we learn to play down our symptoms. We are not observant. We are not oriented. I would rather be paranoid and go get that scan and go get that test than to ignore a symptom and think we are going clean chit. Even then, I know we are at a very high risk of coming down with something without really knowing because of the numbers that I'm seeing. It's just the sheer numbers, 2/3 of the cancer globally today are still going undiagnosed. So we just don't have the right screening methods.
2/3 of cancers globally are going undiagnosed.
But at least we have to be cognizant and oriented of our symptoms. What other risks we are bringing to the table? You and me both have family risks, familial risks. So we have to be on extra alert, higher alert than a regular person who doesn't. But today, if you look around, who doesn't have?
Everybody has.
A person in the family who has been affected. So by that notion, I think all of us have to be oriented, have to be aware, and have to be on high alert of our own symptoms, getting them verified, do the due diligence of yearly checks, but also follow the symptoms. And that symptom could be a throat pain. That symptom could be difficulty swallowing, a cough, a shortness of breath, a blood in sputum, a lump in the neck, a lump in the armpit, a lump in the breast. Anything that you can feel, be aware of your body. I see very, very educated and very savvy women coming with locally advanced breast cancers because they didn't check on themselves. Clinical breast examination is considered one of the most powerful tools to prevent breast cancer or to early diagnose. I mean, catching a lump small is highly curable than catching a 6 centimeter or a 9 centimeter lump when it has already affected the breast surface, when the breast is deformed. So a lot of these symptoms can actually be caught early, investigated early, and result into an early diagnosis, which saves lives. Clearly, the survival is different.
And you have something called the 2-week rule?
I follow a two-week rule. And when you look at the prevention gurus, they generally talk about a 2 to 3 week time span. Why? Because before a symptom becomes chronic for you, check on it. And I would even go on to say, recheck on it if it has lasted long enough. Say someone has had a cough 2 weeks, 3 weeks into it, you got an imaging done, you got examined, did whatever you could for getting that cough taken care of, doesn't go away. 6 months later, you're still battling that issue. Check again. Because sometimes certain cancers actually present as a lesion much later than what you would suspect. Just a couple of days back, I saw a patient in my clinic where the presentation was from back pain. So they said, oh no, we went ahead with investigating the back pain. Nothing showed up. It was only 6 months later that when the patient presented with difficulty swallowing, they figured out that it was food pipe cancer. And by this time, the cancer has already become locally advanced, which means that it hasn't spread to other organs, but it's definitely not small enough to be cut out, has to be treated with other treatments, higher chances of relapse. They did an MRI of the spine.
That didn't show
anything.
So how do you diagnose that? I mean, how do you find out?
So the message is, if the symptom persisted, do another imaging. Very recently, I met another patient where we looked at abdominal symptoms. But all the belly symptoms were coming from the lung. The lung was never scanned, an ultrasound was done. Whenever in doubt, think ahead, investigate a little extra than less. If some symptom is not getting explained.
The problem is that if you have a thing with your belly, you'll go to a gastro who's not going to tell you to look at your lung.
Exactly.
The problem is, like, you're talking about so many traveling connections in your body. Like the guy had a spine, but it was a throat cancer or whatever. So if spine means he'll go to 500 orthos, they're not going to look at cancer. I have some back, everybody has some back thing.
That's the thing, Mukul, that today we are not oriented to the word cancer.
We don't think of that as a possibility.
We are not thinking of that as a differential. What do you do if you're thinking cancer? you at least scan that entire area. You follow through even at a slightly later date, maybe a 2-month interval instead of a 6-month and a year interval.
Right. Talking a little bit more about choosing your doctor and hospital, how does a patient know that they've got the right doctor?
I think we should look out for 2-3 things. One, what are their educational background? We have to be aware of that. Training always counts. Someone who's pedigreed, who's trained, who spent time at large cancer centers in India or abroad have had certain education and training to deliver themselves appropriately.
Right.
Secondly, always look for feedbacks. So look at the reviews and the feedbacks on Google, on various medical referral sites.
Doc, we've talked so much about prevention and screening, but like you said, 1 in 2 people is going to 1 in 2 men is going to get it, and 1 in 3 women is going to get it. So, for all the people who are going to get it, I want to spend a little time understanding what are the right things to do after they've got a positive diagnosis. What is the first thing someone should do when they know that they've got cancer?
Get them to the right doctor, get them to the right center. Cancer treatments are evolving. 50% and even more cancer treatments are actually available. The most novel cutting-edge therapies are only available as clinical trials because treatments are so current.
It's all ongoing.
So new. It's all
dynamic.
ongoing. We are learning on the job. We are trying to better the survival. Those who are living 3 years, we are wanting to make them live 10 years and 20 years. So the best medicine is actually on the trials. We talk about trials. We talk about best treatment. Being oriented to where such treatments are happening, which are the centers that are delivering the best care, becomes very important. And I used to say this even when I was in the US, because when we look at cancer, treatments in the community, in a rural area, in a tier 2, tier 3 city, may be different from a tertiary, quaternary center that may be specializing in that disease process. I feel that here sitting in India as well. I am an oncologist that sees all solid tumors. But when I was in the US, I was seeing lung cancer. I was seeing head and neck cancer. So I was a lung cancer doc. You become disease specific. Your day and night is spent in that particular disease management. So expertise in that particular disease management, that specific disease management becomes very important because it may bring a nuance to the management of the patient. Next fact, for the treatment delineation, strategization, very important to get to the highest center. Then you can come back and get treated locally. But initial understanding should be a multidisciplinary understanding because cancer treatments are multidisciplinary. They involve a surgical oncologist, medical oncologist, radiation oncologist, pathologist, radiologist. It's never ending because cancer is a complicated disease and everybody needs to come together in interest of the patient for the patient's highest survival. So it's very important to seek the best center, to get your second opinions, very important because this is an evolving subject. Data is changing and transforming by the hour. We really need to stay current. We really need to stay connected. We really need to talk to the topmost people, disease-specific people, bring it back home, deliver the therapy in an organized way, continue a very, very tight follow-up and strategic connect with the anchoring center. So I say hub and spoke model, anchoring centers, anchoring treatment
Can you explain that a little more in layman's terms? What is an anchoring center?
So many times people come to Tata Memorial Hospital. They're given a plan of care after Tata has seen the patient and all kinds of different specialties have seen the patient. When the patient is given a plan, patient goes back, gets treated with the local oncologist, but never loses full connect with
suppose we live in India. So let's talk about a cancer. Which cancer would you like to talk about?
Breast cancer.
You have breast cancer. Find the best center in your city or in your country for breast cancer.
Yes.
How do you find that?
So today, everything is out there on social media, on, AI-based curation. I think a lot of information already there. In terms of credibility, some institutions have already established credibility, like the center that I work for. We are being HN Reliance Foundation Hospital. We are listed as #1 in oncology this year. So being aware, which are the centers, where do I need to get to? Even if you're firefighting and you have to start therapy locally, still figure out time, spend money, energy, get to the higher center, confirm your plan or readjust your plan. Do whatever was not done. If everything was done, great. You get that confirmation, reassurance that you're on the right path. So I think multidisciplinary is the key phrase.
A lot of people get, scared to do, like, how do I go to 20 doctors? So how do you do that? How do you find that? Are you saying I'll find a doctor like you, as nice as you, who will say, I will do everything? Is that what it means?
So there is no stopping the patient from going to the surgical oncologist and the radiation oncologist. But you have to understand that these doctors are coming together. Whether they are coming together... But do you have
to go to them, or can you find an anchor center who will get all of them for you?
Best is to find an anchor center who will get all of them for you, like Tata Memorial Hospital, like HN Reliance Foundation Hospital.
So they will do that?
They will do that. You go and see a doctor. Mostly the case will be selected to be presented in the tumor board. And that tumor board witnesses contribution from the surgical oncologist, from the radiation oncologist, from 30, 50 doctors who are sitting down, deliberating, discussing the case nuances, people who are actually objecting to what the primary presenter may be saying. Deliberations are very important because there are variations in each patient's presentation, there are variations in therapies, there are variations in what you would do for that patient. Some patient, I may be proposing surgery where the patient may benefit from getting chemotherapy first. Always there has to be a deliberation around a patient's therapy, strategization. Very important to get that design and then go back to a smaller center to carry out that design. So I say get the second opinion, get your board examination.
Give me a working example.
Right.
Of how, because I don't think anyone knows this.
Yes.
That how someone comes to you with some cancer, with breast cancer, and then it's not only you, but in your hospital there's a board called the Tumour board, which sounds like some weird exam, but it's not, who sits and debates this one person's case.
Yes.
Take me through that properly.
So, I'm going to give you a different example. So, there is a young patient that we are treating with a particular lesion in the brain. And this is highly curable. So, people who are involved are the medical oncologist, the neurosurgeon, the neurologist.
But this person came only to one person?
This patient came to the neurologist with a headache.
Got it. So the neurologist
MRI,
introduced this?
Yes. So the gatekeeper was neurologist. Now the headache can be from various different things. This was a youngster. He could have had
anything,
a problem with his vision, studies, numbers, whatever. This patient gets a scan and is found to have a brain tumor. Now this brain tumor with certain examination was found to be a highly curable brain tumor. The neurosurgeon is called. The neurosurgeon figures out that there is no dire emergency to operate on this patient right now. Medical oncology, which is the chemotherapy doctor, is called. And we look at the patient, we look at the presentation, we look at all investigations, and we decide that this patient can be treated with chemotherapy, and that itself can lead to cure. For such a patient, we need all of us to come together to strategize a management. This is young life at risk. This is highly curable situation. We quickly formed a board. It's called a tumor board. 3 different aspects, 4 different aspects actually. We also called in the radiation oncologist. So you have a surgeon, you have a med-onc, you have a radiation oncologist, and you have a neurologist.
Wow.
All discussing the case together. Many times when we have an urgency and we don't have a physical board meeting that is happening just in the vicinity and we have to start the treatment very quickly, we do a virtual board meeting. We quickly, all of us connect, document, And as per the board, this is the decision taken. We document in our
My God.
electronic medical record. It is a, I think today it's even a medico-legal thing. If a patient gets treated, let's say this patient presented to a neurosurgeon who did not know what he was doing, and he operated on this patient. That would be a big mistake. This tumor should not be treated with surgery unless there is a major emergency and a block in the flowing system. So a board defines what is the right thing to do for a patient. It's not just one person practicing in silo. That is the message that Tata has also always, brought forward. And I have lived with this throughout my oncology career, because I am part of such institutions where I used to say it was like a waltz. You were doing a waltz because you were working with all colleagues together in a patient-centric way. Patient was not moving anywhere. One room for the patient, everybody seeing the patient together, going and discussing in the workroom, discussing with the larger boardroom, bringing the information and the strategy back to the patient, guiding the patient, anchoring the patient, whether the case gets treated locally or at a satellite site.
Unbelievable. How do you all find the time though for one patient to do this?
In India, it has changed a little bit for me. I do not get the time to discuss every single case, but even the slightest controversy, we are one
When
of
you see a complexity, then you straight away bring it out.
very, very quickly. The slightest question in how we are going to manage this patient, very low threshold to put the case in the tumor board.
The drug your mother needed was not initially available in India.
That's correct.
So, when some test or trial or drug is abroad, what should a family do before sending samples abroad?
The drug that mum needed was not in India, and we had to import it and give it to mum. But that is why I'm one of the biggest crusaders in the country for bringing clinical trials to India, because then all these novel drugs, or most of the novel drugs, would be available in the country as they are in the experimentation phase, and we have figured out that they are with promise. We would be able to get
So high
our patients.
potential.
Yes.
Why not use it for people who are desperately in need of it?
And trials also have phases. So early phase trials are testing safety, testing efficacy. But late phase trials, pre-approval trials are already when the drug is ready to be launched. It is just the pharma company doing its last bit.
Yes. Why don't you have clinical trials in India?
We have. But for 1.5 billion of population, we had 453 trials in 2023.
Wow.
We can easily multiply it by 100.
China has how many?
Above 80,000 trials.
They're the leaders now, no?
They are the leaders.
Is that happening?
That's so it is beginning. There is a lot of promise, but we are still way behind.
So small, basically.
Very, very small. And this is just the trials that we could bring from external sources. There is an entire host of development happening in China where drug development is happening within the country.
Yes.
We are zero.
What about AI, doc? I mean, how good is AI today and for the future in finding cancers that people can't find, that someone may miss? Because cancer is so much hide and seek. It's like a detective game.
AI, I feel, is going to be transformative for cancer medicine. Starting from figuring out early warning signs for cancer to figuring out which treatment suits which person, to figuring out which trial is available in which city and which country, to figuring out what drug is going to work on what biomarker. There's so much promise that AI brings to the table for an oncologist. I can only begin to express that.
I'm sure.
We talk about 2/3 of patient presenting in advanced stage. Time is tight. You need to know the right answer.
Yes.
If outside of a patient's body, you can get, I'm sounding sci-fi, but if you could figure this out before giving it to the patient, what is the
Yes.
right treatment?
Yes.
And whatever methodology one could use,
Yes.
from histopathology to genomic information to signs and symptoms that the patient is presenting with, to the data for who got treated where in the world and responded to this regimen.
Yes.
If that information was available to a doctor, to me, when I was sitting at the examination table, wouldn't I want to use that for my patient who's ailing?
100%. You've worked in some of the top cancer centers in the world,
Sure.
Sloan Kettering, Harvard, NYU. What made you come back to India?
So it was merely family. Family was really hurting. I had parents-in-laws, my parents, everybody getting older. And today it's just my dad. So I'm very satisfied that I came back to serve them. But I stayed back because of the connect with the patients and my sphere, body of work in the country.
Amazing. Does stage 4 cancer always mean that the patient has very little time left?
So by the book, yes. But Sanjay Dutt is an example. And you see him free of disease now, more than 3 years going. That's a light at the end of the tunnel.
Amazing. Does palliative care mean the doctors have given up?
Never. I outlined how 2/3 of cancers are getting diagnosed in advanced stages. Advanced stages bring symptoms. Symptom management is palliative care. Palliation of symptoms is not synonymous to terminal cancer.
Palliative is different from terminal.
It's just
Everybody-
palliation of symptoms.
Got it.
Supportive care.
Do you think a patient should be informed if they have stage 4 cancer?
It depends. Indian mentality is completely different.
Yes.
Not everybody is that prepared to hear.
Because culturally, like you said, we're not used to testing. We have developed such a psychosis to cancer.
Psychosis to cancer is the right phrase,
Right.
I think, because the word brings aversion.
Yes. Repulsion.
So, repulsion completely. And so I generally very, very cautious, and I'm actually flagged for this, but I still would be on that side much more than on the side of telling someone in a brash way that they have very little time. Because I think when you are at war, you need to be optimistic and determined that you're going to win it. And unless and until you think that, are you ever going to fight a war?
Yeah. And because in India, it's not culturally part of our thing, you'll just give up maybe. Like the person could be shattered basically.
No, the family gives up. Even
Yeah.
before telling the patient, the family will give up.
Right.
So and inherently also I'm an optimist. So I really believe, and it has been proven so many times that, a patient, Mr. Sanjay Dutt was told he has very little time. Very little time, he was told. I have seen his consultation papers where someone has written palliative care.
Wow.
So palliative care, maybe they meant symptom management, but he was told very clearly that he had very little time in life. And so if you don't present something with optimism and you tell someone they're going to die, is someone going to fight? They're 100% going to die.
So what do you tell people if someone has stage 4 cancer? What do you tell their family or?
Control ho jayega. Cure ho jayega ki nahi? Cure, I can't promise cure, but we will definitely be able to control. We'll be able to give your quality of life back. We'll be able to buy time. And who knows what is there out there in the future. There may be some new drug. If we survive, and that's true, actually, if we survive the next 2 years, the next 4 years, then, the drug that I could not give to my mom, that drug has already launched now and can be given to the next patient.
In India?
It still needs to be bought and brought to India. But at that time, it was not even available to be bought. It was not FDA approved. I could not import it.
And that would have saved your mother?
That would have saved my mother. The drug is called zongertinib. It's available today for me to purchase and bring if a patient has that ailment.
So we used to say time is the biggest enemy, but actually time is the biggest asset. You can, 1 year, every year, there's so much technology.
If you buy time, if you can keep yourself alive for the next couple of years, for the next 5 years, cancer treatments are changing by the minute, and things could be completely different. Who knows, we may have many more trials in our country and access to drugs
Amazing.
than we have today.
What is that one mistake that you see people making when they're diagnosed with cancer they should never make?
Giving up too early, too soon, not getting to the right center, believing in negative messages. Yes, we have to accept the reality, but always be on the side of life, always seek additional information, and always go with the optimistic person. Even if it is 1% misleading,
Right.
leave the side of the pessimist and go with the optimist.
Faith is, even Dr. Vade said, faith works miracles.
Miracles.
So
Absolutely.
why would you discount that?
Yes.
What you don't know.
200%.
Thank you so much, Doc. It was fantastic.